So we have a 41-year-old male and he has exertional dyspnea that is progressive over the last 4 weeks. Pitting pededema and distended JVP are evident on physical examination. That is very obvious that patient is congestive heart failure most likely. Let's see. Which the following substance has been increasingly produced by pulmonary endothelium in the patient? Oh. Well, options are there and now you have to tell which of these substances is released from pulmonary endothelium. Well, the answer to this question is angiotensin converting enzyme, what we normally write as ACEI. Well, this we'll never understand unless we know the basic concept, and one thing very, very clear, this question is one of the most important topic throughout the world. Whichever exam you appear, you are bound to get one question or two based on this particular question. So let's learn the basic concept about juxtaglomerular apparatus, what we call as JGA. It consists of mesangial cell. It consists of JG cells. This is apparatus, this is cells. What are these cells? They are nothing but modified smooth muscle of afferent arteriole. That point has to be noted very carefully. It also include macula densa, which is a sodium chloride sensor part of DCT. This is DCT and this is afferent arteriole. And one more question they ask, various combination PCT, efferent, PCT, afferent, etc. So remember it is afferent and DCT. Well, they secrete renin. Juxtaglomerular cell, I'm talking about this, they secrete renin in response to decrease renal blood pressure. And increase sympathetic tone, which is beta 1. Again, point to be noted. That means even beta sympathetic chain has effect on the JG cell also. Now, macula densa, which is the part which is a decrease, this is senses decreased sodium chloride derivative DCT. And this lead to increased renin release. Now, what is the function of renin which has come? Renin causes it efferent arteriole vasoconstriction. This is via angiotensin 2. Okay, what and how it is going to make angiotensin 2, I am going to tell you in the next slide. But it is the angiotensin 2 which is going to cause efferent arteriole vasoconstriction. Noted, it is efferent. Efferent arteriole vasoconstriction will cause increased GFR. And juxtaglomerular apparatus maintain GFR via renin angiotensin aldosterone system, what we call as RAAS. Okay. Now let's look into beautiful picture of juxtaglomerular apparatus. It consists of, first of all, afferent arteriole, which are JG cells. Then they come macula densa cell, they are the part of DCT. You can see this afferent arteriole. This is the DCT, and finally the supporting cell are mesangial cell. These three together, they constitute juxtaglomerular apparatus. And what I told you, ultimately it is this was the afferent arteriole, this is the efferent arteriole, this one. So it is the efferent arteriole which we are constricted by angiotensin 2, or I can say angiotensin 2 causes vasoconstriction of the efferent arteriole. And now what is going to do? Let's learn more about this thing. So renin is getting released from the kidneys. The point I told you in the previous slide, right? So this was due to decreased BP. Anything decreased BP will stimulate JG cell to secrete renin, decrease sodium delivery in the macula densa, the point I mentioned, and increase sympathetic tone by beta 1 receptor. This also I mentioned to you. So there are three reasons why renin will be secreted. Now this renin will convert angiotensinogen, which is coming from the liver. And this convert angiotensinogen into angiotensin 1. Now, lung endothelium, they secrete ACE. and this will convert angiotensin 1 into angiotensin 2. So now you can see there are three important molecules. One is renin coming from the kidney, angiotensinogen coming from the liver, and ACE is coming from the lungs, right? So now angiotensin 2 has been made, and we learn what the action it is going to do in the kidney. Is going to cause efferent arteriole vasoconstriction. So let's learn more about each of these molecules in detail. So we have a renin secreted by juxtaglomerular cells in response to decreased renal arterial pressure, increased sympathetic discharge beta 1, and now beta blocker can decrease BP by inhibiting beta receptor on the JG. They cause decreased renin release. This point is not known to good amount of people are not aware that beta blocker have a action in the renal also by renin mechanism by decreased renin secretion. Well, angiotensin 2, it helps to maintain blood volume and the blood pressure. It is a potent vasoconstrictor. Okay, constrictor. Now I have a question for you. Question is, it is a very potent vasoconstrictor. Now tell me which is the most potent vasoconstrictor in the body. So write down the answer in your copy. What is the most powerful vasoconstrictor in the body? Answer is endothelin. Okay. So now we got angiotensin 2. So it acts on the angiotensin 2 receptor on the vascular smooth muscle, and that lead to vasoconstriction, and that lead to increased BP. Okay. And when we use ACEI, they reverse this action and they lead to vasodilatation, BP falls. This is the basic mechanism of action of ACEI. Well, angiotensin 2 also constrict efferent arteriole of the glomerulus, and that lead to increased filtration factor to preserve renal function, especially when the renal blood flow is reduced and the body want to maintain GFR. This is by efferent vasoconstriction. Okay, how come? Let's learn. Let's say this is the afferent, and these are the capillaries, and finally it is the efferent is there. This is normal. They are the glomerulus. Now this is the afferent, is the efferent. Now when angiotensin 2, this is the afferent remain like this, glomeruli, and now efferent has constricted. So now the efferent has constricted. Look into this diameter and this diameter. So definitely when this passage is narrow, that will lead to increase pressure in the glomeruli, and that will lead to filtration. Simple physics. Now, well, everyone knows that angiotensin 2 are the very, very important part in taking part in stimulating aldosterone, and they lead to increased sodium channel activation, that lead to sodium and water reabsorption is there. Then many of us are not aware that they even stimulate posterior pituitary to secrete ADH, and that acts on the aquaporin, and that causes increased water reabsorption. The point to be noted, angiotensin also stimulate ADH release from posterior pituitary. So we learned that in DCT they are acting via aldosterone, but they also have an action in PCT, and they cause sodium reabsorption. Okay, sodium reabsorption, and that can permit contraction alkalosis also. And finally, they stimulate hypothalamus and they stimulate thirst also. So in addition to action in kidney, there are so many other action also angiotensin 2. Now let us look into other option. Aldosterone, it is we know very well it is secreted from zona glomerulosa, from the adrenal gland. It's not coming from the from the lungs, and it regulates sodium and water reabsorption. It responds to low blood volume state. ADH, it comes from posterior pituitary. It only absorbs water. ANP, BNP, they are released from ANP is released from atria, and BNP is from ventricle of the myocardium. They are secreted in response to increased volume. The main action is natriuresis. So they keep a check on renin-angiotensin. We are well aware this RAS system, so-called renin-angiotensin-aldosterone system, they tend to absorb sodium and water. And who will keep a check? By ANP, BNP. Once the extra sodium water comes in, ANP and BNP are released and they lead to natriuresis. They relax vascular smooth muscle via CGMP, cyclic GMP. They increase GFR, they decrease renin, and they dilate afferent arteriole. Point to be noted, angiotensin was causing efferent arteriole constriction, and this is causing, they are dilating the afferent arteriole and they constrict efferent arteriole, and that's why they are going to increase GFR. Point to be noted very carefully. So golden line to remember, juxtadermal cells, they secrete renin in response to decrease renal blood pressure, increase sympathetic tone beta 1. Macula densa decrease, they sense decreased sodium chloride delivery to DCT, and it lead to increased renin release. Ultimately, both are going to cause increased renin release. So we have a 65-year-old man. He comes to the emergency department with severe right leg pain. He is found to have an acute thrombotic occlusion of the right popliteal artery. He has a hyperlipidemia, type 2 diabetes, hypertension also. And he is admitted to the surgical floor and initiated on intravenous unfractionated heparin. The following morning, he undergoes surgical revascularization of the right leg. The patient hospital course progresses well, but 5 days post-operatively, his platelet count decreases from this to 65,000. The vital signs are stable. Surgical wound is healing well. There is no rash or pitting edema. The most appropriate next step in the management of this patient is, well, the answer is stop heparin and start ergotropan. Why this the answer? Why not others? Well, what is this case? The patient was started on heparin 5 days back. Now, this is a heparin-induced thrombocytopenia where the platelet count goes down. Let's learn the basic concept about HIT. Well, we suspect heparin exposure for more than 5 days, like in this case, it is 5 days exposure. And any one of the following: platelet count reduction by more than 50%, like in this case also. Arterial or venous thrombosis, in this case, it's a popliteal artery thrombosis. It is there. Necrotic skin lesion at the heparin site. There is nothing like this in this patient. Acute reaction after heparin, of course, this is acute thrombotic episode only. However, the 5-day criteria is there, and any one of the following, and there are 2 criteria which are definitely meeting this. So this is, now we can say this is a case of HIT. Now, HIT is a life-threatening complication of heparin therapy. HIT may manifest sooner in patient in previously exposed to heparin. Like patient was already given heparin, now it may happen in 1 or even 1 to 2 days, 3 days also. Otherwise, it may occur even longer than 5 days, maybe 7 days, maybe weeks, or more than that also. But we need at least 5 days of heparin therapy. But again, repeating second time, if it has already been exposed, the duration may be less than 5 days also. It's an antibody-mediated phenomena, and this lead to mild or moderate thrombocytopenia with minimal bleeding risk. Point to be noted. Although the count is reduced, it is not a bleeding, but more of a thrombus formation is the main problem. That is something, a unique thing, that we are getting low platelet with increased clot formation. Well, if venous and arterial thrombosis risk is as high as 50% cases if HIT is not treated. How we really diagnose? Serotonin release assay, the gold standard confirmatory test for this. Start treatment in which suspected before you get a report. So we are thinking this is a case of HIT. We will send this test, but we will not wait for a report. Start the treatment. What the treatment is, I'm going to discuss in the coming slides. Treatment is all heparin products, including low molecular weight heparin, should be discontinued immediately. Stop, like in this case, stop heparin therapy. Patient, remember, this HIT can be occur with a low molecular weight heparin also, although the incidence is much less as compared to heparin. Okay, heparin has much more, this is much less. Well, we need anticoagulation. They should be non-heparin like ergatoban or fondaparinux. Well, write down the answer in your copy. I have a question. What is the mechanism of action of ergatoban and fondaparinux? Write down the answer. Well, as far as ergatoban is concerned, it's a direct thrombin inhibitor. Okay, this is factor 10A inhibitor. Now, let's look into other option. Continue heparin and obtain serotonin release assay is absolutely wrong answer, though no way it has to continue, so discussion also needed. Stop heparin and order platelet transfusion, no way, say antibody mediated, and you have to give anything else anticoagulant, otherwise it's going to have more and more clot formation. So diagnosis of HIT is confirmed with a high titer of immunoassay or functional assay, but discontinuing heparin and initiating non-heparin anticoagulation is the treatment of choice, and we don't wait for the report also. Platelet count typically normalizes 2 to 7 days after stopping heparin, and transfusion are not required unless patient is bleeding, which is very, very uncommon in HIT. Switch to low molecular weight heparin, again wrong answer, because we have to stop. Remember, this can happen with low molecular weight heparin also, that there is no question of starting low molecular weight heparin. Well, option E is incorrect. Stop heparin and start warfarin. Warfarin is used for anticoagulation maintenance in patients with HIT. It's never given in acute attack. This is started only after patient has received another anticoagulant and the platelet count is in the normal range. The platelet count has normal range, then we can start warfarin. But now I have a question for you. Write down the answer. Why initial treatment with warfarin is contraindicated in patient with HIT? Write down the answer. Well, the answer is initial treatment with warfarin is contraindicated in patients with HIT as rapidly lower the protein C level, which may transiently increase the risk of thrombus. Golden line to remember: suspect HIT require immediate cessation of all forms of heparin, including low molecular weight, and initiation of anticoagulation with the treatment like argatropan and fondaparinux. Warfarin is never started immediately. It should be started later on when the platelet count has come in the normal range. Okay. Well, I hope you liked the session. Just to inform you, we have following courses for you. Smart Medicine. There are 350 hours of pre-recorded video lecture of whole internal medicine. It includes all super specialty and allied subject, covering A to Z, including basic concept about every topic. Second, we have tests and discussion. There are more than 1,000 questions with discussion of the questions, sample question and discussion you saw in this session. Now, third thing is Medicine Simplified, which is a textbook of medicine. Harrison is the ultimate book to read medicine, but it is too vast. Reading one page of Harrison, you need half an hour. To understand, you need 2 hours, but you need only 2 minutes to forget what was written in that page. Then what is the solution? We have Medicine Simplified. It's a textbook of medicine, but so-called mini Harrison. It's a summary of what you need to read from Harrison. The book is available in Amazon also. Now, these 3 things are more than enough for your MD, DNB medicine and family medicine final exam preparation, NEET SS exam preparation. You don't need to read any other book. These 3 are complete in all the aspects. For more detail, you can contact at this number. It's a mobile as well as WhatsApp. And this is my personal email ID. Anybody want to reach to me, you can contact me at this email ID. Thank you very much.